Hello. Oh, hi. How are you guys? My name's Josh, one of the second-year medical students. Welcome to... What's... It's not a big deal. Thank you so much for coming out to the SSUNDA night tonight, where we're going to be talking to Dr. Marco Raftopulos. Before we begin, I'd just like to make acknowledgement of country, and then I'll introduce Dr. Marco. So we acknowledge the traditional owners of the country on which we meet today, the Gadigal people of the Eora Nation. I'd like to also pay respect to the elders past, present, and also the elders in the future. So, Dr. Marco Raftopulos, so we're really honoured to have Dr. Marco here today. Of course, he is Nikki's older brother, and we're so honoured to do medicine with her as a second year. Dr. Marco Raftopulos finished at Knox Grammar in 2002 and commenced medicine at UNSW in 2003, graduating in 2008. In 2009, he started his internship and residency at Royal North Shore Hospital. After working as a junior surgical registrar for 3 years in New South Wales, he was accepted onto the ENT SET training program in 2014. Dr. Raftopulos completed his FRACS exam in 2018 and completed his training the following year. During this time, he was the Australian ENT Trainee Representative for 2 years. He has also written 6 publications and has presented both nationally and internationally. Please welcome Dr. Marco Raftopulos.
Thanks, Josh. It feels quite weird to have that kind of read back out to you. It's weird because like a blink ago, I was kind of sitting where you guys are sitting. So it's this, as I was saying to Josh before, it's actually a really good thing to have this. You know, early on when you're a medical student, you often have no real idea about what you want to do or what path you want to kind of head down. I certainly had no idea, to be perfectly honest. I certainly had no idea, even once I'd finished medical school, what I wanted to do. So just not to be too self-indulgent, when I did finish, I was convinced I was going to be a cardiologist, 100%. So I was going to do interventional cardiology. And so I just remember that when I finished, I got my internship at North Shore. So I started at North Shore, convinced that that was what I was going to do. And I started my first job doing Gen Med at North Shore, which was in the old red building. I don't know if you guys know. Anyway, it was this old building. It was like level 11 or something like that. And it was actually the Gen Med / the medical assessment unit, which is just old people with cellulitis. That was it, just old people with cellulitis. And we just did ward rounds all day. And then I just realised I can't do that. That's not something I can do. I can't do a ward round all day, every day. So I realised pretty quickly that medicine as a pathway for me, or physician's training, was not something that suited me. And so for the next couple of years, like internship and early residency, basically dabbled my way through the various specialties. And that's the advantage of doing an internship and residency, is that you are forced to try a bit of everything. And so you should use that to your advantage, both to rule in and rule stuff out. So I think tonight, really practically, what I was going to just talk you guys through is what decisions led me to the point of doing the training that I did, what the process was of getting onto training and getting through training, and what are the little bits of gold that you can get in terms of helping you go down a particular path, right? Because what you think you're going to do now is probably not what you're going to end up doing, you know, realistically. But if you can work out, and this is what I basically say to every single person who's interested, the only decision you have to make, not even now, but soon, is are you going to do surgery or are you not going to do surgery, right? That's your first branch in medicine. Because after that, relatively speaking, everything's a lot easier. Your non-surgical pathway, you have at your advantage time, and you can take your time getting through physician's training, pediatric training, you know, the rest of it. Critical care, ICU, ED, those are all fine, but those are just time in lieu type of training programs. And it's not to detract, that's what they are, that's the advantage of them. Surgical training takes a long time to get on, it's highly competitive, and to get onto training programs in surgery, you have to be committed to that one particularly. So you're kind of throwing your eggs into a basket, and then once you're down that path, it's a little bit hard to pull yourself out of that way. It's not to scare, it's just so that you know, right? That's the decision you kind of have to make early on. But once you've made that call and you've chosen to do surgery, then that clarifies things for you. It allows you to just simply say, okay, this is the type of medical student I am, this is the type of junior medical officer that I am, and you can position yourself in the most favourable way to get yourself into the jobs that you need to then help you get onto the training programs that you want to get onto. So this is really close to the truth, this whole thing. This is how you are. Basically, this one is how you are for most of your junior training, and this is how you are for most of your senior training. So you're just tired, mostly, and angry. You're a lot happier. That's not true. You're a lot happier once you're done. You really are. But getting there can be tiring. This is absolutely what you look like when you start. So anyway, so I just thought, before I get into great detail about ENT specifically, I just thought I'd kind of whet the palate for you guys in terms of what we do, so that you get a bit of a taste of what my job is like. And so, more as a consultant. You definitely do a bit more of that later. You never do that before then. Anyway, so we do a lot of this. So a heap of what we do is your run-of-the-mill tonsillitis, tonsillectomies, obstructive sleep apnea, kids, adults, working up people with breathing disorders, sleeping disorders, and then managing this either medically or surgically. You get to spend a lot of time talking to people about the pros and cons of surgery, being able to discuss with them why they do and don't need surgery, and eventually getting to do this type of stuff, which is actually quite fun. It's not too difficult, relatively speaking. It's high turnover stuff. It's interesting kind of work as well. So that's basic tonsil stuff that we do. This clinical photo is one of an eardrum. What you're seeing there, I know you guys probably haven't done too much ENT, but just to kind of make things simple, it's an eardrum which demonstrates, it's a right eardrum, and it shows, if you guys can see here, a fluid level. This is white underneath here, this is pus. So this represents acute otitis media, so something that we commonly deal with. Children requiring grommet insertions and being able to remove fluid from the middle ear to improve hearing in children so that they can have better speech and language development and so that they can participate more in class. This is very kind of iconic in terms of what we do. But having said that, though, this is just tip of the iceberg kind of stuff. There's Indigenous children, Indigenous health, Indigenous ear disease, massive part of what we do, and then complex ear disease. Just to take this one step further, we have evolved in our specialty to move a lot towards endoscopic stuff, and I'll show you in more detail, but this is an endoscopic view of the middle ear. Once you've removed the eardrum, and you're looking at that same view, but this is the eardrum removed. And what you're seeing here, this structure here is called the malleus, this is the incus, this is the stapes, this is the oval window, and the round window is down here. When we do cochlear implants, we come in through the bone and we make a small hole here and we insert a cochlear electrode into that. So that is what part of what we do is, in addition to the simple stuff, we do complex stuff. And this is where ear surgery is going. It's going endoscopic. At North Shore, for instance, all we did was endoscopic ear surgery, the kind of stuff that previously required big microscopes. We just do with a camera all down the ear canal, which is actually pretty extraordinary. This is a little one saying that she has rhinorrhea. Oh, it doesn't tell. That's my daughter. Anyway, whatever. So snotty-nosed kids, you get them all the time. They're a lot of fun to have. Pediatrics is a wonderful part of your practice, right? So you have this really gentle part of ENT, which is really good. But then there's your training, right? So everyone, I don't know what your perception is of what ENT does, and probably that former is what most of you think. But then we kind of do more stuff. So this is a kid who's got something called orbital cellulitis. And orbital cellulitis can be either involving the eyelid or it can go deep. And when it goes deep, it starts to enter into the orbital cavity, and it's often generated from an infection from the sinus when it transmits through the ethmoid bone into the surrounding structures, right? When that happens, they get this red eye. And what happens then is that they can lose their eye very quickly. So what you're seeing there is a CT scan. This is called the axial, and this is the coronal view. And can you see this bowing over here? This is pus in the kid's eyeball. right, or adjacent to the eyeball. What it's pushing here, I don't know if you guys have done much eye anatomy, but that's the medial rectus, and it's essentially pushing the medial rectus laterally because there's a collection of pus. Now, you would have thought that's something the ophthalmologists manage. It's certainly not. They're not really surgeons. No, they are surgeons. They don't have a FRACS. It's fine. It's cool. They're not really surgeons, but they are. No offense to anyone who wants to be an ophthalmologist. So what we would manage with this child is we would do this endoscopically. So up through the nose, we would open up the orbital bone. We would decompress that, and we would remove the pus through the nose from the eye. So an example. Now this, you guys are doing a gastro term, I think. This is Crohn's disease of the larynx. Very uncommon. We wrote this up. This was at the pediatric hospital. So in addition to what we do in terms of our airway stuff, so just to kind of orientate you, this is an incredibly abnormal looking larynx. This is called the epiglottis. The vocal cords are in the distance there. You can barely see it. But what you're seeing here is Crohn's disease. And what this alludes to is a lot of what we're doing in ENT is a lot immune modulatory type of medicine. So to be an ENT surgeon, you have to understand the immune system. You have to understand it in great detail. And a lot of the immunotherapy that we use, both in this kind of extreme example, but also stuff like allergy, allergic rhinitis, this is all an immunotherapy challenge. So we have to understand that in great detail as well. This is a child with a lymphovascular malformation. We had to secure the airway in this kid. This enormous mass we have to dissect out, so it requires a big dissection there and removal of all of the fluid. That was a lateral tumour, highly exophytic on the side of the scalp. And that's what we do, we dissect that out. So that's the dissection post-operatively. What you're seeing there is the skull, you're seeing the internal jugular vein, that's the sternocleidomastoid, that's the temporal bone drilled out because tumour was extending so deep into it. And essentially what you can't see on view, but it's the facial nerve is going to be dangling over here. This is right towards the apex of the petrous temporal bone. And this is the dissection of all the lymph nodes over here, and the parotid gland was removed from the front of this guy's face. That is this patient, she was a challenge. This was I'm just literally getting palpitations thinking about it. So she was a challenging patient, is a challenging patient who has got a borderline personality disorder. And what she does is that she swallows razor blades every week. In fact, 3 to 4 times a week. So when it gets to here, we have to take it out. And when it gets to here, the gastro guys have to take it out. So we tend to push it a bit further. Anyway, no, we don't. We don't. Maybe once. No, we don't. So what you're actually seeing there was when I had to take it out. And what you do to take it out is you take a big, something called an esophagoscope, which is a long metal rod. And with the patient suspended, you basically take it down, put it down their esophagus, looking down with the light source, and you try and pull it out. What you're actually seeing there is a bit of esophagus that's just been hoiked out with it. So there you go. That's a 2 a.m. special right there. This is a young man who has got something called a juvenile nasopharyngeal angiofibroma. So which is a vascular tumour in juvenile or young men. And it essentially erodes posteriorly in the back of the nose and enters into this area called the infratemporal fossa, which sits just behind and below the eye. And so what we have to do to access this tumour is endoscopically through the nose. We open up the maxillary sinus, we take down its back wall, and then we scoop it out with coblation. But before doing that, they need to be embolized to prevent massive blood loss and all that type of stuff. So kind of a cool case. This lady had something called a pleomorphic adenoma. So a pleomorphic adenoma is a benign tumour, which when we remove it generally from the parotid, has got this incredibly frustrating propensity to have these little pseudopods. If you don't scoop out the pseudopods, it's not a malignant cancer, it's just a benign one. But if you don't take out the pseudopods, they reform. And that's what we've seen here. This lady had something scooped out many, many years ago. They didn't quite get it all out, didn't get a capsular dissection on the lesion. And so what you're seeing there is a massive recurrence on the side of her face in the place of the previous lesion. So that was fun. That is a tumour of the larynx, which requires a dissection of the neck. So you take the neck lymph nodes out, you take the voice box out. That is a maxillary sinus tumour. that requires a dissection of the face. So we make an incision in the front of the lip, we make a cut around here underneath the eye. In this instance, if you can see, I know you guys haven't seen this before, but you recognise that this is the orbit, and you can recognise tumour going into the orbit, right? So as part of the dissection of the cheek, we also have to remove the eye. So that's called an orbital exenteration when we do that. So we lift the skin, we do a neck dissection, we take out the entire maxilla and the orbit. When I was doing this, when we were removing the orbit round the back, what we didn't appreciate at the time of surgery, because the tumour had escalated in size so much, was that it actually eroded the anterior part of the carotid artery. So when we did the cut at the back, which dissects the optic nerve out of the cranial cavity, basically blood just hit the roof, and so in that instance, you change your underwear, you literally shit yourself, and then you apply pressure, and then you think deeply about your life choices. And then you take them down to interventional radiology and you get them to coil off the internal carotid and hope they don't stroke. And he didn't, which was great. He survived, which was exceptional, unexpected. And then he walked out of hospital. So there's that. And that's just some guy who just let his scabby ear just get super scabby. Gross. Anyway, that's a sense of also what we do in ENT, right? So a lot of what we do is gentle, but a lot of what we do is also pretty interesting. So that's kind of where the specialty is interesting, because you really can choose to craft what you do in a very in a very specific kind of way. If you are a head and neck junkie and you just want to rip out big cancers, it fits you. If you want to be very nuanced and you want to be an otologist and you want to place cochlear implants and do inner ear hearing reconstruction, you can do that. So there is a lot of diversity within the field, and that was part of the reason why I liked it, to be honest. You could actually choose anything. So what I didn't actually really realise when I was first looking into ENT is the qualification of ENT is ENT and head and neck surgery. So we are head and neck surgeons, otolaryngologists. Now you can do head and neck surgery either as an ENT, because that's part of our qualification, or you could choose to do gen surg, and then go and do head and neck. But the truth is that if you do it through ENT, you're far better trained, because it's what we do every single day, right? So if you like the neck dissections and the cutouts and that tickles your fancy, then you're in a much stronger position to do it through ENT training versus general surgical training. But anyway, so how do you get into ENT? I'm sure you guys probably have a sense of this already. You probably would have spoken to a few specialties would have had a chat with you, but I'll just kind of walk you through this very specifically. You're going to finish up in a couple of years' time, and then you're going to want to do then you're going to have to do your internship. So the way the internship process works, I don't know if you've been told this, is that you put in your preferences into a ballot, right? What they do is they take your preferences, they put it into a pot, they take that pot, and then they just run around naked. That's it. Then they take out your name, and that's what hospital you go to. So good luck to you in terms of that. But if you can, apparently you can, stack and all this kind of shit. I wouldn't worry about that. I think just put your first preference first, and you do your best to try and get the internship that you want. At the end of the day, there's movement, especially in the residency year. So if you don't get the internship that you like, you want to try and get yourself into a hospital residency program somewhere else. So you can move, you can apply, you can ask for transfers, you can do all of these things. That is possible within the realms. Your JMSU officer is a junior medical staff officer who is your God, who will tell you where and when to work. You can, if you be good to them, they can be good to you too. So if you are interested in ENT, and I'll keep this very ENT focused, and you want to do an internship, you should be looking to do internships at North Shore, Vinnie's, Prince of Wales, Westmead, because those are the funnels, unofficially, those are the funnels by which you get into the ENT training programs, right? You could do your internship elsewhere, but you're not going to be exposed to the teams that have got the most amount of influence, or the most amount of, influence is the wrong word because it's very transparent, but the most amount of exposure, I guess, to the specialty that you'll want to do. So for ENT, those are the ones I'd be looking to do a job in. And you should make yourself known to the ENT service early in those hospitals. Show that you're keen, attend their meetings, you know, be present in their theatres if you have time off. Residency, you're really trying to make sure that residency is the year that you're lining up for your SRMO year, which is your Senior Resident Medical Officer year. So you're trying to make yourself attractive to be hired the following year as a junior surgical resident or junior surgical registrar. So residency, again, you want to be in those major teaching hospitals because those are the ones, the feeder hospitals for ENT, realistically. Plastics is different. I don't know if you've had a plastics talk yet. I don't know if they've talked about this, but there's different levels of how good the job is at an unaccredited level. There's the official unaccredited ones and there's the unofficial accredited ones. We're not quite there, but there are certainly places you want to be. As an SRMO, it's 1 to 2 years you're going to sit there being an SRMO, and that's your surgically focused year. You have to do an ICU term in that year, you have to do ENT in that year, because you're not going to be in with a chance for the following year to get what's called the unaccredited ENT years. So in your SRMO, you're still every quarter changing to a new thread. So you're going to be doing ICU, you'll do Gen Surg, you'll do nights, and then you'll do maybe ENT or maybe plastics or something like that. I say plastics because often ENT plastics are a combined job. When you get the unaccredited, this is when you're a little bit more, people see you a bit more seriously, I guess. Up until this point, you know, it's all a bit, you're keen, but you're not quite there yet. Unaccredited year means that you are an ENT registrar and you are only an ENT registrar, but you are not on a training program. To get those jobs is very difficult. It's highly competitive and you are not supported. So you're not part of a training program, you're not part of a hospital. Politically, I don't know if you saw in the paper, there was the girl who did plastics and she was an unaccredited registrar, and the problem there was that she didn't have a body to fall back on. As a JMS, as a junior medical officer here, you can fall on your union and your JMSU and all this kind of stuff, but as an unaccredited, it's actually quite an unfair system because you don't actually have one hospital necessarily employing you, and you can be exploited to some extent, which we all were, but that's fine anyway. So you do this for 2 or 3 years realistically, right? So if you are gun hot, you will get onto your training program 5 years after you finish medical school. Not trying to be a downer, or, you know, but realistically speaking, that's where you are to get onto this kind of stuff. So once you're on the training program, you generally takes 5 years to finish. You've got 2 big exams. You've got your basic sciences exam, and which I'll get to in a second, and you've got your fellowship exam, which you do in your final year of training. And then afterwards, you can choose to do an extra year, a fellowship year. So fellowship is something that for instance, I'm doing a fellowship year. I'm going next week, heading off with my family, going to Amsterdam to do more skull-based surgery. So it's a cool year that you can do away after you've done everything you want to do. So the basic surgical exam has swung as to when you could originally do it. Not to kind of go too much in the history, but the bottom line of that is you can now do that exam the moment you step out of medical school, right? And I encourage you, if you are surgically minded, to get that exam over and done with quickly, because you cannot get onto your ENT training program until you have done that exam. Right? So that is, without being too cynical, a phenomenal way for the Royal Australian College of Surgeons to make a lot of money off you guys. So it's $2,000 to $3,000 a pop, and it's, you know, 50-60% pass rate. You have to learn lasts. Do you guys know what lasts is? Cover to cover. It's character building experience. Layers of the foot. Fucking foot. Anyway, so you have to learn them all, and you have to learn them in great detail. And you also have the first 10 chapters of Robbins, and you have Ganong and all this kind of stuff. You apply your ass to a seat, you learn the content, you get through. It's not terribly challenging, you just need to put the effort in. So once you've got that exam, you then sit the interview, and then you get onto the ENT training program. So that's your timeline. Cool? Any questions? Anyone want to walk out? Still got you? All right, so let's go through it. This needs to be your best friend if you're actually looking at doing this training program. Go to the Royal Australian College of Surgeons website, surgeons.org. So this is the front page of it. There's something here called Becoming a Surgeon. It's just garbage. Don't look at this. There's a bit that's below here, which I should have included, but if you look down here on the bottom right section below it, you're going to see each of the specialties lined off. You're going to see plastics, otolaryngology, head and neck surgery, orthopedics, etc., blah, 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 top to bottom. Click on the ENT or the otolaryngology one, and it'll take you to this. Now, I just thought I'd put it on just to be a bit of a jerk, just to kind of show you guys kind of how it worked. So this is national entry numbers per year. So this was the biggest they'd ever had. Yeah. Righto. So, things that you need to have completed by the time you are applying for the training program. Now, don't worry about the top, right? You're either going to be in the group that's going to be competitive or you're not. But to be competitive, this bit down here, the mandatory requirements, is where you need to start looking, okay? And why this is important is because when you go into your internship or your residency, you are having these things in mind, okay? Because you cannot even apply for the training until you have done these things. So OHN obviously means otolaryngology, head and neck surgery. So you need to have done 10 weeks of ENT before you apply for the surgical training program, right? You need to have done 20 weeks of surgery in general, which means at least 2 terms or 3 terms in surgery. You need to have done 8 weeks in ED. These 2 ones are actually okay. The top one is hard to get. That's why you want to be in a hospital that does ENT, because the biggest chance of you being able to get an ENT term is if you're in a hospital that offers ENT, and they don't all offer ENT. It sounds obvious, but it's a really important factor if that's what you're looking at. This one is an interesting one, ICU. ICU is highly competitive because not only ENT, but all surgical trainees, all anaesthetic trainees, all intensive care trainees, all ED trainees need to do an ICU term, right? And I think even some physicians need to do an ENT term. So it is highly competitive. So when you arrive at your hospital, you find your junior medical staff unit officer, you arrive with a massive box of chocolates, flowers, whatever it is, and just say, please give me an ICU term, because that's your key thing, because actually an ICU and an ENT term. So you've got to hit your minimum requirements, right? Once you've got your minimum requirements, then you can start thinking about applying. So, bear with me here. When you are going for the selection process, you will obtain a score out of 100 when you're entering into the program. The score is divided into 3 components: a structured CV, referees, and an interview, right? You can control the CV. You can kind of control the referee reports, and you can prepare for the interview. I know this is a while away, but it's kind of not as well. It's something to think about if this is what you're actually interested in. So let's look at the CV. There are 20 points allocated to the CV. Go to the website. It tells you in very specific what you can get a point for and what you can't get a point for, right? For instance, presentations and publications, a maximum of 5 points. So if you were going to, for instance, do a case presentation, which is the simplest and easiest way to get published, that's worth 0.25 of a point, right? If you're going to be the primary author on a review article, that's worth 3 points. So the savvy person looks bang for your buck, right? You're never going to get 20 out of 20. No one ever does. It's just obscene. And if you are getting 20 out of 20, it's because you've hung around so long not getting on the training program that you're 20 out of 20. So I don't mean that bad. I mean that in reality, that's kind of what it is. So when you're looking specifically, get your bang for your buck points, right? This is important, structured referee reports, because you're going to have to ask referees from both the surgeons that you work for and also the non-surgeons. Now, the non-surgeons include your theatre nurse unit manager, the ward nurses, the occupational therapists that you work with, the speechies, the head and neck, CNCs. These are your non-referees. So bottom line is, and obviously for so many reasons, and not trying to be too, transactional about it. But you've got to be nice to everyone. Otherwise, it'll come back to bite you, And the reality is, working in a hospital, it's so much easier. You get so much more done if you are lovely and pleasant and honest and appreciative of the people that you work around you. So the worst thing you can do as an intern is be pushy and annoying and ungrateful. If you can say thank you to the staff around you, if you can be good to them, they will absolutely be good to you. So that's just on the side and side. But anyway, that's why this is important, because you're going to have to impress both the people that you work for in terms of your surgeons and the people who are non-surgeons. Finally, the interview. The interview is held in Melbourne. You know when you get off the plane at Melbourne and they've got that hotel, I think it's like the what's it called? The Hyatt? What is it? Yeah. Oh. I can't get out of Melbourne Airport and not just feel nauseous every time I get out of Melbourne. It's the worst place. Anyway, Melbourne's nice. Melbourne's nice. Don't get me wrong. That specific thing, looking up at that hotel. Oh. So they got a foyer and everyone is just shitting themselves and, anyway. My advice is try and enjoy it. Anyway. So if you're getting to that point, there's a whole bunch of different interviews. You'll get past questions. You'll get new questions. That's kind of the gist of it. So that's kind of an overview of how you get onto and into the training program. So what does ENT... Yo.
Sorry, just a question. The qualifications bit, whereas I think I read it, people are doing masters and PhDs.
Yeah, exactly.
Actually having to do those to get enough points to get...
So people will do that to some extent. You'll find a lot of the people who you're going to be starting surgical applications for will have done a master's or at least part of a master's. Just read the fine print on the master's stuff, because some masters count and some don't. And if you're, for instance, going to do a surgical master or masters of surgery, then it has to be the one where you do more than 1 year. There's one of them, so just look very specifically. Previous degrees, I was reading it before, previous degrees, Carl, if you've got a dentistry degree or you've got another fellowship from a different college, so say you've gone and been a gen surgeon first, then I think that gives you a point. I don't know how. And it becomes harder, to be really honest, when I was going through, this is just terrible, honestly. When I was going through, it was 5 points for skills courses. So every time you went to a course, you got a point. So now it's maximum 1 point. So you can do all the courses you want, it's just 1 point. It's brutal. Anyway, so that's kind of, and the truth is, all the specialties are kind of like this. They all are. They take few numbers, but if you do position yourself in the right place, you do the right work, you build your CV, you give yourself a 3 to 4 year plan. This is how I'm going to build towards this. I'm going to pick up these research projects quickly. I'm going to be efficient in my allocation or acquisition of points. Then you'll find yourself competitive if, in addition to doing... Yeah. No, go on.
With the publications part,
yeah.
Again, not sure how true it is, it's more like a written thing. I've heard that they only count publications that are in the previous 5 years or something.
Oh, no, that's a good point. I think in some specialties that's the case, and I think in ENT there might be some limitation. I think it has to be within 5 years or 6 years. So I know a lot of you guys probably did research already getting to this point. It may not be valid. I've lost him. Everyone just walks out. So I think, despite this, don't get me wrong, this is an absolute nightmare. It is. Getting on's a nightmare. But, people get on. They do get on. And I was absolutely not a research gun by any stretch of the imagination. I did the bare minimum from a research point of view. I got the most number of points I could. I worked really hard as a junior. I made myself available and I was happy to be involved with the team, and you go with the flow and you give yourself the best opportunity to be liked and you work hard. That will get rewarded. But you know, it's a hard slog to get on. Getting on is hard. Getting through training, not that it's harder, it's just different. The tempo raises, and you really feel once you're on the training program that you are now part of a really quite serious training program. They are training surgeons, right? This is not play school. It's proper training, and so there is an expectation of performance, which I think is appropriate. There is a very clear expectation of what surgical trainees need to do. There's well-documented criteria of what is and isn't competent. You know, you never get the feeling on, I don't know what's right and what's wrong. There is a clear criteria. Have you achieved this, and this by this stage? If people get kicked off training if they don't hit their criteria, so even after all of this stuff, you know, there is a group that don't make it through. If you fail terms, you don't work hard, you don't work well with your colleagues, you can get kicked off training. Not a large number, a small number. I was on the training board. It's very hard to get people kicked off training, and for all intents and purposes, they don't want you to get kicked off training. They want you to stay on, but they need you to hit a level of competence before passing you at the end. Your final exam is character building. It's one of the most traumatizing experiences you'll ever go through, but nevertheless, a year later, they're doing the exam this weekend, and I am horrified for them. So it's literally coming up. I think it's in Melbourne this year. It was in Sydney last year. Your final exam is done over 3 days, and it's this 3 days where you just get tested on everything. And then on the Monday, you stand outside a room and they open a door, and then you walk in and there's an envelope, and you open the envelope and they'll say pass or fail. So. So have I lost you? Is everyone still here? No? Anyone walking out? Anyway, it is what it is. They've evolved this year. You got a text message, pass or fail. Anyway, but if you get through, which most people do, realistically, if you get onto the training program in ENT, 99% of trainees get through, right? They do. They might take a fail or two, it might take a little bit of extra time, but most people get through. So the bottleneck is getting onto the training program. That's why that's the hard thing. Once you're on, really you have to monumentally fuck up for you to be told that you can't be on the training program anymore. I know that because I saw that. So your bottleneck, don't worry about the training. The training is a privilege. The getting onto the training is tough, and that's your bottleneck. So work towards that as your goal. So you get a bit of everything. You really do. The other thing I was going to add to the list, I was thinking about this on the way here. The other thing on top of all of this stuff is cancer malignancy and very elective stuff. Cosmetics is part of what we do if that's something you're interested in. The best rhinoplasty surgeons in Australia are ENT surgeons, as much as the plastic surgeons might tell you, they're not. And the reason is because they understand that plastic surgeons are phenomenal at aesthetics. They are so incredible, and we work with them closely for reconstruction, because say for instance we're going to chop out a great big tumour from the face, right? They will reconstruct that, and they will do the most magnificent job doing it, so hats off to them. For rhinoplasty, what they are very good at is cosmesis, but the problem is, just as a mini tutorial on cosmesis of the nose, most people, the reason why people want their nose addressed is they want their nose by and large made thinner, right? Thinner and smaller and narrower. You know, that's the aesthetic that most people aim towards. And so in doing so, you functionally reduce the size of the airway. And so what you should be doing at the same time as addressing the cosmesis is functionally inside the nose, creating space to compensate for that. So that's where, for instance, rhinologists and ENT surgeons are much better well-trained. So putting that aside, facial reanimation, facial plastics, all in the domain of ENT if you want it to be so. But kids, old people, resect, like one of the tumours that we were doing, you're resecting dura off the brain, you see brain on view, you know, terrifying but cool. Micro and macro, you're dealing with big stuff, you're dealing with microscopes. Once you've finished, it's wonderfully conducive with life as surgical specialties go. I'm not talking about being a dermatologist, I'm talking about being a surgeon. And if you're going to be a surgeon, you know, your life is actually pretty good. Once you're finished, you have a lot of control. My day started at 9, well, 8 this morning, finished, no, today's a bad example, but like yesterday, started at 9, finished by 4. It's a really lovely day, you know, very easy. I put this ratio as in better than the rest, and I mean that comically, and you know, and also as a point, you know, surgical training, by and large, has had to improve itself. It has not been a place that's been good for women to work in historically, but the entire organisation is making amends, I think, to try and make it far more appropriate place for people to work in. And really, it was unacceptable how it had been, and now it's moving to a point where it's better. Now, in terms of ratios of numbers, ENT's got the most number of male to female ratios, which is something I think is fantastic, personally, versus other specialties that have far less. So that's a good thing. Wonderful colleagues. Everyone's a bit of a hoot, to be honest. That's why I liked it. It's part of the reason why I chose it. I like the people who I worked with. And that's a big thing of the decision that you make. You've got to fit your personality and the personality type you are into the surgical specialty you're going to do, right? It's no good thinking like an orthopod and wanting to be an ENT. It doesn't work, right? You know, you've got to lift those knuckles off the ground. No, it's fine. Joking. No, it's fine. There is a personality type. There is a personality type for each of the specialties, and you've just got to find what suits for you. As we talked about, it's competitive. To get into ENT training, you need to have done a lot of ENT, and what that means is that you've not done a lot of other things, which means that at the pointy end, you're probably going to have a lot of ENT under your belt, but if it doesn't work out for you, it can be hard to change direction, so caution. You really do belong to the health system when you're a junior medical officer and throughout your training, and what I mean by that is, especially when you're junior, especially when you're unaccredited, you're going to do nights, you're going to do day shifts, night shifts, you're going to be owned by the hospital. So that's just part of it. And in our specialty, once you're on the training program, yeah.
Sorry, is that specifically for ENT or is that like broad stroke?
What belong to the health system?
Yeah.
Oh, yeah, broad stroke. Absolutely. 100%. But as a surgical trainee in particular, not ENT, but surgical trainee in particular, you're really much at the whim of the hospital. In terms of ENT, once you're on the training, you're probably going to need to do at least 2 years outside of Sydney as well. For us, it's not that big a deal. That means Wollongong, Newcastle, Gosford, Canberra, Darwin sometimes. It's quite an interesting term. You do a lot of Indigenous years. So that's kind of your cons. But look, I picked it because it suited me, it fit my personality. I was never going to do medicine in terms of physician's training. I liked the idea of doing interventional stuff, but I just couldn't stomach doing EPT training. So I chose the harder thing instead, so that's fine. But anyway, the other stuff, ED, ICU, they're all great. They're wonderfully conducive with life, but not quite my style, right? So you've got to pick what works for you. And then once you're done, it's great. Life's a peach, right? But it is hard to get there. Cool. Anyone have any questions? Any practical questions? Just general stuff? Please email me if you have any questions at all, right? Yeah.
What was your journey in terms of, like, don't mind me asking?
Oh, yeah, what did I do? Yeah, so I was in internship at Royal North Shore, internship residency. I did an SRMO here at Vinnie's, where I managed to do an ENT term / plastics term. And then after that, I got an unaccredited job at Wollongong, and I was there for a year. I then did the unaccredited job at Sydney Children's Hospital, and then I got into the training program. So that was my kind of journey through. And I just remember the second year, because the first year in Wollongong I applied, I had to go at the exam, at the interview, and I had to go at the interview, and I was, I had a good interview. I just wasn't in the realm of competitive at that stage. My CV was too low. It was fine. The following year, I missed out by 0.25 of a point getting onto the training program, but then I got a second round offer, so it was kind of cool. So I got on that way. The other thing to point out is the college is really strict about when you put in your application forms. So if, say, you put in your application form, say you want to apply and you're interested, there's something called a pre-application or a preset process. Look it up on the website. If you don't apply by a certain date, you cannot apply that year. There's no late fees, there's no late entry. You're in by that day or you just don't get it. So they're brutal about it. I know that because I applied once and I was late. Anyway. It was for urology, it was different, but anyway. So yeah, urology is also a great specialty, by the way. But anyway. Any other questions? Yeah.
What was your interview like for 3 interviews?
So it's a pretty daunting experience because you're there in a room, you're there with a lot of other people who, like you, have been spending a lot of time trying to get onto a training program. The actual experience of the interview is very quick. You do 3 15-minute, so you're in the room for 15 minutes and you do that 3 times and there's 2 questions given to you in that 15-minute period, right? So you have a minute of reading time and then you have 2 questions given to you and then you finish and you go to the next room and it's you in a room with 2 interviewers. All happens quite quick. You can prepare for that. A lot of people, that's the thing that they fall down on, right? They are not good at interviews and they've never been good at interviews. I think for a group like this, who's, you know, more experienced, you know, has done a little bit more, has sat a few more interviews, has gone through an interview-based entry into medicine, you're probably in a slightly stronger position than you realise, right? I went to UNSW, but mine was the interview year, the first time I did an interview, and that just served to my strengths, you know. I never got 99.95, you know, that was never what I got. So I think if you are a confident person and you've done a lot of prep, those interviews are manageable, definitely. Anything else? Yeah?
When did you sit GCSE?
When I was going through, you could only sit it once you're on the training program. So it changed, which I think is a good thing because there were a few ENT people who got onto the training program and then failed the GCSE and got kicked off the program, which is brutal. But, you know, you get 3 or 4 goes to do it. The advantage of doing it pre is that you're unlimited in the number of goes in which you can take it. It's expensive, but you can, you know, you can use it. It's all a tax deduction. Yeah.
How did you fit in, like, having a family?
So, yeah, I had a family during my surgical training. For me, that added a bit of balance and perspective. It helped me get through my final exam. When, like, our little one, like, she was full on. So you do a whole day of work and then trying to get her to sleep, and then you say, well, I've got 4 hours in which I need to be productive. And so it actually forced me to be very streamlined in my study, and also offers balance because people get, you know, you get really swept up in the training program and you feel sometimes like you've got nothing else around you. For me, it helped having a family. I would say most of the ENT trainees are either married or have kids. Most of them. And that's also a reflection of life. People are getting on further and further. People are getting onto the training program later and later in life because it's harder and harder to get onto. And, you know, most people sitting in their, you know, early 30s are probably in a relationship. You know, there will be a few that would have had kids or, you know, will be starting to think about it, and that's reasonable. So I think it helps you if you can, you know, let it. Anything else? Haven't scared you off?
Full disclosure, I'm from Melbourne, so
don't
hate me. But yeah, Marco, thank you so much.
Pleasure.
On behalf of the Specialty Society here at Notre Dame, I really want to thank you for coming along.
Thanks.
And sharing your personal journey and some of the unique and fascinating cases you've worked on.
Thanks.
But I think most importantly, comprehensively taking us through the process by which to get onto the training program. It's incredibly insightful, quite terrifying,
Yeah,
personally,
I
I
really
find.
need to find that. It is what it is.
But I think, when it comes to us making that informed decision,
Yeah.
we're all the better for it. So as a token of our appreciation, a bottle of wine and this very
Keep cup.
stylish keep cup.
Thank you so much.
Thank you.